So good evening, everyone. Thank you very much for all of your support by connecting together in this free webinar series. Some of you know me, some of you don't. My name is Dr. Gurnam. I am an aesthetics doctor here in the UK. Some of you have seen me present at some of the world congresses, for example, IMCAS in Paris or AMWC in Monaco. So hi to everyone that knows me, and hi again to everybody that doesn't. First of all, it is a bit of a shame that everything has now come to a bit of a standstill with this whole COVID-19 issue. So I just wanted to say thank you to everyone, all you practitioners out there that are now coming together and supporting each other, because I know it is a bit of a difficult time for everybody. And some of you may ask, why am I doing this webinar series and why is it free? Well, it's a way of giving something back to the aesthetics community, which does consist of plenty of physicians around the world. Some of you may be new, or some of you have just started going, or some of you might just want to refresh your memory. So the whole point of this beautification series is purely to give you a bit of a recap in facial aesthetics. You may learn a few things, or new tips or tricks, and I'm going to put it out there straight from the beginning. This is purely for educational purposes. If there's anything that you don't like, don't use it. If there's something that you like, then please embrace it and use it in your own clinical practice. So there will be a series of 7 webinars held at the same time every week. I will apologize just now. This is the first webinar, and it's to do with botulinum toxin. Now, I'm a big fan of using Botox, but it's difficult to try and make a very exciting presentation sometimes from such a simple, effective treatment. So obviously, from next week onwards, the webinar series will be including things to do with dermal fillers and complications and treatment areas of the whole face. So as the weeks get on, they will get more and more interesting. So I'm just going to switch the screen around so you can see my presentation. So welcome once again. There is a Q&A button on your screens, your devices, so feel free to click on that if you want to ask me any questions. I can't really see anything at the moment. I just see my full screen, and that's it. So I will try and answer them as we go along. Otherwise, I will answer all the questions at the end. Each of the webinars will be around 30 to 40 minutes, and then the remainder 15 to 20 minutes of Q&A. So this is part 1, back to basics. So botulinum toxin type A. So what do we know about Botox? So just starting off introducing Botox. So it's a toxin produced by Clostridium botulinum, and there's 7 main serotypes. And type A is the most potent and long-acting. This is going to vary amongst various countries, but it was approved in 2006 in the UK for the use in the glabella region. Very long clinical history and a huge wide margin of safety. So a lot of patients that will come see me for the first time, I will make it very clear to them that Botox is essentially one of the safest things you can have in your face. You're not going to be having skin necrosis or vascular occlusions or causing visual loss. So it is one of the safest things documented to be injected for both cosmetic as well as medical reasons. And here on the left-hand side, you'll see that there's a list of medical indications. Some of you may already be doing this. Hyperhidrosis and chronic migraines are quite common, and you've got various other indications. Just a little bit about the history. Here in the United Kingdom, we've got 3 main brands of toxins. So we use Botox, Azolor, and Bocuccio. And obviously there are variations such as Vistabel, Dysport, and Xeomin. Now, my personal preference is to use Bocuccio purely on the basis that it's not cold chain. I've had good results, And there's also the financial aspect, which you do need to consider if you're running your own business. And they do all have their own properties, and I will be addressing that in hopefully one of the latest slides. So just having a very quick look at how Botox works and looking at the pharmacology. So you can see these, the slideshow here. So here we have a nerve, and here we've got the muscle. And in between is what we call the synaptic cleft. And within the distal aspect of the nerve, we have these little vesicles containing a neurotransmitter, obviously in this case, acetylcholine. Now, Botox will essentially bind at the nerve ending, be engulfed within the nerve itself, and then into each of these vesicles. And then it prevents these vesicles from binding on to this postsynaptic cleft. Therefore, there's no muscle excitation afterwards. And in theory, we believe that there are sprouts that are forming at the nerve endings, which is why it's a very gradual approach that the lines in the face eventually do come back. Just a little bit of fancy terminology here for those of you that really like your molecular biology. It's a single inactive chain polypeptide, and you get certain enzymes or proteases which basically split the molecule into two. So you get a light chain and a heavy chain, and they're connected by disulfide bonds. So that's that on a molecular level. So just looking at the contraindications and cautions here, we've got a list of cautions. Now, cautions, keep in mind, means you can still go ahead and treat, but you do just want to keep, be a bit wary, so to speak. So OCD, so obsessive compulsive disorder, or body dysmorphic disorder, unrealistic expectations. And that's a very key caution. Sometimes you get over energetic patients that come in and just say, look, I want to be smooth as ever, and I want to get all my lines gone. And sometimes it's nice just to educate them and inform them that we're essentially just softening the appearance of the lines. We're not trying to remove them straight completely. The chances are we will remove them completely, but we're just softening the lines. So I always under promise and over deliver the results. Anticoagulants, again, shouldn't matter too much when it comes to toxin, but again, just be a bit wary, risk of bleeding and bruising, and obviously stay away if they have local infection. And here we've got a list of contraindications, so anaphylaxis, known hypersensitivity, and obviously pregnancy or breastfeeding, and interactions with certain aminoglycosides, which are a type of antibiotics such as gentamicin. Now, some neuromuscular conditions, in fact, quite a fair few can be treated. However, in a cosmetic practice, they will be a no-go. So just looking at the classification again of wrinkles or lines, if you like. So keep it very simple. Nothing as in type 1, and then type 2, 3, 4. It's pretty much mild, moderate, and severe. So it's a very well-known international scale, which is good for documentation purposes and assessment. Now, one of the questions I often get asked is, are injection techniques important when it comes to botulinum toxin? Now, when it comes to dermal filler, hyaluronic acid, we need to decide which layer of the face are we injecting the product into. Is it a bolus? Is it a linear thread? Is it fanning? Is it a high G prime product? Is it a very cohesive product? We've got all these factors to decide. And typically, I don't know if you would agree, but for most of us practitioners, when we all started out in aesthetics, we started out learning Botox, botulinum toxin injections. And then you get the hang of it and you think, oh, that's very straightforward, fairly easy, very low risk, quite difficult to get a complication. And therefore we move our practice mainly onto fillers, and we focus a lot on fillers. But it doesn't mean that Botox, just because it's a straightforward procedure, that there aren't certain technicalities to it. So looking at this slide, certain things to consider. Dilution volume. Now, I have used Azello. I believe that may also be known as Xeomin. I have used Azelor and I have used Botox. And as you can see here are my dilutions. So for Azelor, I would use 0.67 mil and Botox 1.25 mil, pretty much stock. So quite standardized if you ask me. Have I ever over diluted, so hyperdilution of toxin? Yes, I have. For example, in the perioral region, when we are wanting to treat barcode lines, smokers lines. So there has been a study done by J.S. Dover back in, quite recently actually, a couple of years ago. And he did conclude that dilution volumes do not matter. Okay, what matters is the experience of the practitioner. So if you know how to hyperdilute, by all means do it. And there are right and wrong times when not to do this, such a thing. But there isn't one rule fits all. So just because I use a standardized measure of dilution doesn't mean I'm doing things right or wrong. And some of you may be using a hyperdiluted solution. Again, each to their own, and as long as patient safety is kept paramount. Injection depth is another important factor. So IM intramuscular and ID intradermal. Now, one thing to keep in mind when it comes to the face, it's slightly different to, for example, the limbs, the arms and the legs, where we have compartments. Therefore, we can get compartment syndrome. Whereas in the face, it would be very difficult to try and achieve compartment syndrome. Now, the point I'm trying to get at here is within the face, the effect of Botox is 3D. So whether you place it in a superficial layer or deep onto periosteum, Botox will spread not only in its field, but also perpendicularly and vertically. Okay. Now, in terms of what depth do I inject in, again, there is no right or wrong answer. However, studies do dictate that the deeper you inject, the more likely you are to have a complication. So for example, in the frontalis muscle, if you were to inject intramuscular and you do go quite deep, you're likely to have a greater field of spread, therefore, theoretically, higher risk of having a complication such as brow ptosis or blepharotosis. And there are certain parts of the face where I would only inject intradermally purely because I want the products to remain quite superficial. For example, targeting extremely dynamic lines in the mid-face where we definitely don't want to be going in deep. Pain. Now, this is going to be very subjective, and the gold standard in terms of injecting is a yellow 30 gauge needle. Could be whatever color, to be fair with you, but it's a 30 gauge needle. Now, the study was done by M. Allen in 2015, where he was focusing on the needle size and the perception of pain. And he concluded that using a 32 gauge needle or above, so 33 or 34, will cause significantly less pain. He also concluded that we should be using bacteriostatic saline and not normal saline. So bacteriostatic is preservative containing saline, which tends to be your benzyl alcohol. And again, that would cause less pain. And very interestingly, there was a study done in 2017 by J.J. Fuchs et al. And he was looking at comparing pain on the left side of the face and the right side of the face. So I'm sure some of you would agree, some patients, when you're injecting fillers or Botox, they'll say, ow, that hurts on this particular side or on that particular side. And I believe over 300 patients were in this study, 302 if I'm not mistaken. And they concluded that the left side was the more painful side. So as a rule of thumb, always inject the left side first. So coming on to intradermal and intramuscular injections, as I was saying earlier on. So intramuscular is when you're going to be going slightly deeper with the needle and you're going to be reducing the muscle strength. So an example would be the masseter. You're going to be going nice and deep and you really do want to reduce the force in the muscle. And then you have intradermal. As the example I gave you earlier on, when you have fine lines or crepey skin, especially in the lower 2/3 of the face, that's a very good place to be hyper diluting the Botox and then injecting very superficially into the intradermal layer. And what exactly happens, and as you can see here, what I've written is immediately you get a fibroblast cytoskeleton rearrangement because of the volume placement of your solution. And this is going to cause collagen arrangement and therefore lifts the dermis. So this will immediately soften any very fine lines that you may have. Then the delayed treatment outcome is you have fibroblast stimulation because of the trauma, collagen synthesis, which leads to increased skin thickness. And these are just some areas where I've just given you a good example of where I inject. So if it's a procerus, corrugators, or the mentalis, masseter, it is intramuscular, so I'm quite deep. And I'm intradermal for other parts of the face. For example, crow's feet, so the orbicularis oculi, orbicularis oris, platysma, and frontalis. So botulinum neurotoxin type A is very versatile, and let's look at some good examples what I mean by this. So you can use it on all skin types. It can be used for skin tightening as well as lifting, which goes to show what I was talking about in the previous slides about injecting IM or ID. Textural improvement, again, hyperdiluting and injecting intradermally in the lower 2/3 of the face. Sebosuppressive, so helping sweat glands. Shaping and contouring, so whether this is for calf toxin or facial toxin in the lower third, or hyperhidrosis is another factor. Acne scars, and it can be used in combination with other treatments. So as you can see, it's a very versatile treatment with a huge safety net. So what is beautification? So let's just take a quick selfie first. That's not me, by the way, if some of you haven't gathered. So what is beautification? So this is a non-surgical approach to restoring facial balance, therefore optimizing beauty. Now, this involves treating the whole face as a whole rather than individual lines. What I mean by this, as an example, is many years ago, we would see the classic nasolabial fold, and you would just go in, do a linear thread, and inject a product. Now we're looking at the face as a whole and looking at the bigger picture. And it also involves using every tool that you have in your toolbox. So toxin as well as hyaluronic acid and anything else that you can offer, whether it's chemical peels or threads. And the most important thing is we are trying to create the best version of the patient. We're not trying to create a new person. And sometimes that's quite difficult to put across to your patient, especially when they come in with a picture saying, we want to look like Angelina Jolie. And you're like, right, that's not going to happen. So always try and rationalize outcomes with your patient. So how can we adjust facial features? So some of you may know who this is, and for those of you who don't, this is Margot Robbie. The first thing what we're going to be doing is looking at the outline of the face. So this is what I do initially, and keep in mind here, we're only talking about botulinum neurotoxin in this webinar, so no fillers, but that doesn't mean you do not look at the outline of the face. So the patient may have or may want a more oval face or a heart-shaped face, and this can be achieved by using botulinum toxin. So how do we assess for beautification? Now, I always look at the upper part of the face first and then work my way down, just my method of working. And the eyebrows are going to be the first aspect where toxin can be used to try and create a change with regards to beautification. The second place to look at would be the oral commissures, and the third place would be the jawline and the masseter. So this is your famous triangle of beauty, or the triangle of youth, and as you can see, gravity, disproportion, descent, everything heads south, and the triangle becomes inverted. So the focus on the toxin, by looking at this image, would be looking at the brows and giving that nice high arch laterally, trying to thin the jawline, and trying to lift the oral commissures. If you look at this picture over here, Okay, so these things are going to be helping to not only lift the face or lift them, stop the muscles from pulling these elements down, but also beautifying the face too. And as I said, beautification is a combination of using toxin and fillers. And it's a nice little formula to think of. What we're doing is we're rebalancing elevators and depressors of the face. Male versus female. Now, this is a very interesting point. Now, I often get asked, do we need to change the dose for male patients? And the answer to that question, personally, over time has been no, we don't. Now, most male patients of mine, I will still use the same treatment dose as I would if it was a female patient coming to see me for the first time. Obviously, at the 2-week review, if they need more, I will be adding more. So you don't necessarily need to add more from the get-go. And this is what I've found that has worked. Now, certain characteristics are going to be a bit different with the male face and the female face. For example, women wanting high arch brows and a more oval or a heart-shaped face. And this was a very interesting paper from several years ago, back in 2011, by A.C. Little, and he was focusing on the facial attractiveness and looking at the evolutionary basis of attraction. And what he found from this were 4 points which objectively identify beauty. And the first point was symmetry. So if you think about it, if something is naturally more symmetrical, we're going to appreciate it. For example, even if it was a flower or a tree, if the more symmetrical something is, the human mind is more inclined to think that's going to be beautiful. Averageness, I think that's where we are in nature and in life in general. And one of the conclusions from this paper was that being average works. So not being, how do I put this, too ugly or too beautiful. So being average actually contributes to beauty and works. Secondary sexual characteristics in the faces, for example, having a wide face, lower face if you're a male face, or having high arch brows if you're a female. And finally, the skin health, the texture of the skin, the color of the skin, and the age of the skin. So these are the 4 points that were concluded. However, this is purely for just to give you a bit of an insight. It still doesn't mean we need to treat the male face any differently. Okay. Now, in terms of complications, I'm going to split these two in two, and then we'll talk about some more interesting stuff afterwards. So I always split complications into injection-related and toxin-related. So something that could be injection-related, for example, would be pain, bruising, and quite rarely, actually, a hematoma. You tend to be injecting fairly superficially when it comes to using neurotoxin, so therefore hematoma is pretty much rare. But pain and bruising are quite common. And then you get toxin related. Now, I'm not going to be covering every single one of these, but if you do have any questions, feel free to ask me. So classic complications would be asymmetry, having a mild headache post-treatment, and the rest of these tends to be quite rare. So iatrogenic botulism, so if you overtreat, browtosis or blepharosis, periocular edema, diplopia, dry eyes, and any skin reactions. Now, things like dry eyes and diplopia or periocular edema tend to be from injections from the crow's feet, so for the lateral part or the orbicularis oculi. And diplopia actually is very rare. I think I've come across one case of this, and that's injecting the neurotoxin extremely deep, and there is spread to lateral rectus muscle, which is going to cause mild palsy, and in return that will cause diplopia. But it is quite rare. One or two of these complications I will be covering later on. So intense headaches. I'm sure some of you have had patients whereby they've said Hey doc, I'm experiencing some mild headaches after treatment, and they can start anywhere from the first 1 or 2 days, and they can last up to 7 days, sometimes a little bit more. Now, this is called idiosyncratic botulinum toxin type A induced headache, and there was a study by J. Carruthers in 2002, which is quite a multi-center, double-blind, randomized controlled study looking at the efficacy of botulinum toxin and the safety aspect. And there was a large number, I can't remember the top number off the top of my head, but 15% of the patients did complain of headaches post frown line, the glabellar region toxin. Now, this is self-limiting, otherwise your normal over-the-counter painkillers may help. It's quite interesting, and the reason why I've included intense headaches is because toxin can also be used to treat chronic migraines, which is something I do in my practice. So it's just something to be aware of. If some of you have come across this or haven't, that you shouldn't be alarmed thinking, I've treated my patient, and all of a sudden they've got a banging headache, and you're thinking, why is that happening? I thought it treats headaches. Okay, so just be aware that you can get quite acute headaches which self-resolve. So looking at the functional anatomy, now this is probably the most important thing when it comes to using botulinum toxin. And as you'll come to know, when we start doing the future webinars, they're going to be more on hyaluronic acid. And the main point there is knowing your vasculature. Whereas for botulinum toxin injections, you don't really need to know much about the vessels, but you do need to know about the muscles. And these muscles on this beautiful diagram, if you look here, are, I would say, the very basic muscles that you should be knowing. And we can run together through them. So before I answer, maybe some of you can answer as well in your own heads. So here, starting at the top, we have the frontalis muscle. We have your procerus over here with your corrugators on either side. You have your orbicularis oculi muscle, large sphincter-like muscle. Then here we have your nasalis, and over here we've got the levator labii superioris alacoid nasi muscle, which is an elevator of the lip. And then lateral to this we have the zygomaticus minor, zygomaticus major, and then down here the risorius. You can have a look at this side. So here again is your levator labii superioris alacoid nasi muscle, which does have two heads. This is what we inject toxin into when we're treating gummy smiles, just in this region here, right next to the alar base. Lateral is zygomaticus minor, zygomaticus major, and beneath them over here, which is slightly deeper, we've got a levator labii superioris muscle. Here is your risorius muscle. This is your masseter. In this region here, you'll have your lateral and medial pterygoids. This is your DAO, your depressor anguli oris. Medial to this is your depressor labii inferioris, and then here you have your mentalis. Deep to all of this, you have a round circular sphincter-like muscle here, which is your orbicularis oris. So again, these are the basic muscles that you should be knowing if you are using botulinum toxin on the face. Okay, so retaining ligaments. Now, again, I was just touching base on anatomy there. This probably isn't overly to do with botulinum toxin, but it is useful to know. And it's a question I often get asked is about the ligaments of the face. And there's various ligaments, as you can see in this diagram, but essentially what these ligaments are deep fibrous attachments that originate at the periosteal level, or even the deep fascia, and then they travel straight up through all the layers in the face, and they attach onto the dermis, or the skin. And essentially they are anchoring points within the face. They stabilize this mass, and they stop the face from basically moving around. Okay, so let's look at challenging zones here. So this is all from personal experience and feedback from colleagues. So the 4 challenging zones that we have are the upper third, so the frontalis and the glabellar region and the brows, the nasal tip ptosis, the perioral region, in particular the DAO and the platysma. Now the perioral region is obviously very complex. There's a lot of muscles all attaching at the modulus and at the orbicularis oris itself, but we're going to be focusing predominantly on the DAO and the platysma and the jawline. So we'll be focusing on the masseter. So we'll be going through each one of these one by one. So again, try answer this in your own heads as to what the muscle is before we talk about the muscle. So here we have the frontalis muscle, and it's very interesting to look at the shape of this muscle. It is a rectangular like shape. However, it is there is no muscle fibers in the medial portion. Okay. So looking at the forehead lines, so before we even think about treating the forehead, it's important to know the underlying anatomy. And as we can see in this picture here, that it is a triangle-like shape, and then it originates at the Galea aponeurosis, and it inserts pretty much into the orbicularis oculi and the procerus. What does that mean? That your frontalis muscle is the main elevator in the face and the only elevator of the brows. As the diagram that we have on the right here is very important, and just keep this in mind. We'll talk about this when we talk about the complications. Sorry, just running a little slow here. Okay, so looking at these two examples here, before and after, as you can see. So what we're trying to show here is everybody's different. Now, just because we've seen what the frontalis looks like in the previous couple of diagrams, doesn't mean it's going to be looking like that on every single face. And I've seen a lot of practitioners that when they're teaching, for example, they will say at the level of the brow, you need to inject 3 centimeters up or 5 centimeters up, or put 3 fingers here and then you inject toxin along that line. And I find that quite of a bit of more or less a wrong way to teach. It can be used as a guide, but where do we inject? And the way I always say is just assess the patient clinically. So raise your eyebrows. That's what your frontalis does. And if you think of all of these lines here, think of them like railway tracks. So that's a railway track, that's another railway track. And I often find the highest one, which is just here. You can see it takes a bit of a dip medially and then it picks up again. So in this region is where you're going to be injecting the botulinum toxin. And again, my preference is to inject intradermal here, not intramuscular. So in terms of injection points, you'll see here in blue, these will be the points in both of these cases. So you'll see that I am quite high up. And the reasoning behind this is if I were to inject Botox in the lower half of the muscle, the patient will complain of forehead heaviness. Now, the dotted red line is me just visually splitting the frontalis into an upper half and a lower half. Now, often if you're going to be treating the frontalis, it makes clinical sense to be treating the glabellar region too, because both of these muscles have opposing effects on the brows, a bit like a tug of war. But if you're solely going to be treating the forehead for whatever reason, it might be financial for the patient, then only treat in the top half. The blue marks are your base injections. So you can see 2 laterally and then 1 in the middle, medially. And then depending on action of the frontalis when contracted, you can see that I've added 2 more injections slightly lower down, but again, maintaining to be in the top half. Same with this example here. You can see the contractions of the frontalis muscle and 2 extra insertion points over here. Now looking at the male face, so this patient, as you can see, is trying his hardest to raise his eyebrows as high as he can, and there is hypercontraction on the patient's right-hand side over here. So following the same principle, I would inject in the top half of the patient, of the face. So let's see if I can get the next, yeah, there we go. So draw the imaginary line, splitting the frontalis into top half and lower half, and then you've got your 5 base injections and 2, if needed, slightly lower down. Now, this is his result, bang on 2 weeks later. You can see that this is him trying to actively raise his eyebrows. So the difference is quite significant. However, there are still quite a couple of deeper lines lower down. Now, this could just mean that he needs more toxin to be added at this stage, or even treatment at the glabella complex. Now, this result was still achieved from just using a standardized dose of Botox, sorry. So the same doses that I would have used in these two female patients was used in this male patient as well. Right, so next muscle group. So let's get your anatomy caps on. So let's have a look here. So this is your glabella region, and these are your focal points. So if you have a look at this diagram here, you have your procerus here in purple down the middle, then you have your corrugator, and then you're going to have your depressors, which are in this region down here. Okay, so in terms of the action of these muscles, they work in conjunction with one another, and they will pull the brow down and medially. So let's look at some examples of injecting in this region. So a couple of patients of mine, and you can see the variation in the type of frown they have. And I'm sure you'll all have come across this, that no two patients are the same. You can see on the top right here, we've got the classic 11 lines, and down here on the bottom left, we've probably got 1011. You know, we've got various lines. So again, using a standardized dose of Botox, and I will try to get my markings up for you if I can. There we go. So you can see they're not exactly symmetrical or vertical or horizontal or whatever you want to call them. And why is that? It's because I was purely analyzing the face on contraction. So clinical analysis will dictate to you where exactly you're going to be injecting. So in this case here, there was 7.5 units of Botox injected deep into the procerus. So this is an intramuscular injection, and then to the corrugators and the tails. And you can see the depressor supercilii on each side of the procerus here, which also pulls the brow down. And in this case, you can see that I've also added a second injection into this procerus. And that's not gold standard. You usually just do one dose of toxin, 7.5 units, and instead here I did 5 units and another 5 units of Botox here. And you can see still a fantastic result. Brow lift, let's look at it, how we would do a brow lift. So you've got a few potential options: a chemical brow lift, which is using your Botox at the tail of the brow, medial frontalis injections, and hyaluronic acid. So looking at these eyebrows, we would be injecting at the tail end of the brow, away from the orbit, intradermally, just a small dose, for example, 2.5 units of Botox. And this will relax the superior lateral aspect of the orbicularis oculi, and the frontalis muscle will then be hyperactive and allow for a brow lift. Another way is to purely inject the frontalis muscle. However, instead of doing your 2 lateral injections here and here, you just bring your injections slightly more medial. Therefore, the lateral part of the frontalis is still hyperactive. And the third point I've mentioned here is hyaluronic acid. Another lovely way of giving a brow lift is injecting either with a needle or a cannula filler into this region, or better still, my preference is injecting into the temples, which tends to give a longer lasting result. In future webinars, we will talk about things like needle versus cannula and aspiration, etc. And I'll try and make them a little bit more exciting. So why is it challenging? So these are real cases. So here on the left-hand side, we can see this brow ptosis. So if you look at the actual iris, so you can still see pretty much the same volume of iris on either side. So it's a brow that has significantly dropped. Yes, there's an element of lid ptosis too, but the brow has dropped. Now, there's a couple of things that we can do here. So we could, one, potentially do nothing, just watch and wait, reassure the patient, and reflect on your injection technique. Alternatively, we can drop this brow ever so slightly. Now, this would require, again, minute injections of toxin and intradermally in this danger zone region. Now, in terms of education from this, your safe zone is being medial to the mid-pupillary line. So when you see a patient, if you visualize the mid-pupillary line, you do not want to be injecting Botox lateral to this unless you're injecting the frontalis, in which case you are quite high up. So the danger zone is pretty much lateral to the mid-pupillary line and only 1 centimeter. So often, I'm sure some of you would have had patients whereby you do the Botox, you review them in about 2 weeks' time, they have an amazing result, and they'll say, if I lift my brow, I've still got 1 or 2 creases here. And then you think, right, I can't really do anything there because I'm going to cause one of these 2 outcomes. And you're right. So that's something to have a consultation with the patient beforehand and just manage that expectation. Now, again, if somebody was to have some lateral creases here, what would I do? I would potentially still inject a tiny amount of toxin, but again, being above 1 centimeter. So, for example, let's just take a look at this case. So if this patient had creases in this region here, where you see my pointer, this is your danger zone, 1 centimeter above the lateral brow. So still being above this, I would inject a tiny amount of Botox, maybe 2 units, and intradermally, and that will soften the creases that we get laterally here. So coming back to this case, again, this is usually self-limiting between 4 and 8 weeks. And you've got two main options. You can either drop this brow or just watch and let it resolve itself. It would be quite difficult to try and lift this brow. I mean, as you can see here, the drop is quite significant. And on this side, what we can see is eyelid ptosis. So if you actually look at the actual iris, you can see there's a lot less visible on this side. And this is because the injection's been too close to the levator palpebral superioris. And from personal experience of managing complications, I find that iodopine eye drops tend not to work, or when they work, it's very short-lived. But if we're going to go by evidence-based medicine, iodopine eye drops, which is apraclonidine, 3 times a day in the affected eye until it's fully resolved. So moving on to the next challenging part of the face. Now, some of you may do this, some of you may not do this. And this is the focal point here. So we've got the dilator muscles of the nose, and it's this muscle here. So do we know what this muscle is? So let's look at nasal tip ptosis. So on this patient, it may look like I've done some fillers. I have been lifting the piriform fossa, as you can see in this region. However, there has been a subtle increase to the tip of her nose, and you can see, look at the curvature here and look at the curvature here. So no filler has been done in this patient. This was purely from an injection in this region, as you can see with this arrow. And if you take a look at the tip here and compare it with this side, you can see there's a lift. Okay, now this treatment was done 2 weeks prior to me doing the nasolabial fold treatment, in case some of you are wondering. Obviously, you wouldn't be getting a lift straight away on the same day. So this picture is 2 weeks after this picture, just so I could show the effect of Botox. Let's have a look at the next slide. So again, the muscle that we are injecting is the depressor septi nasi muscle. And this is injected basically in the nasal spine, as you'll see on the next slide over here, there. So you can see that we're torting the skin by pulling the nose up, and this part here is your nasal spine, and we're going to be injecting 2.5 units of Botox right into this region. So why would we do this? Well, the obvious reason is for nose ptosis. So the tip of the nose is pointing slightly downwards. Now, this may not be a concern for many patients. However, it is a concern when it comes to animation or expression. Now, what I mean by that, and I'm a classic example, is the tip of my nose is nice and straight. Now, every time I smile, the tip of my nose moves down slightly. So if I was wanting a non-surgical rhinoplasty or a liquid rhinoplasty, and my concern was I want my nose to be straighter, then the first thing I do when I'm assessing the patient is I get them to smile and look at them from a lateral profile view. And if when they smile, so they're expressing or they're animated, and the tip of the nose moves down, then they will be a candidate for Botox. So I call this the dancing tip. So every time they're smiling or talking, the tip of the nose is pretty much just dancing away. So this diagram shows you exactly how you would inject 2.5 units into the base of the nasal spine. And to answer these questions, why would you do it, is if they've got a dancing tip or nasal ptosis, if you like. When would you do it? Well, this is what you would do, especially, well, one, if they come in as this being their presenting complaint, I'm not happy with my tip, or two, if they're wanting a non-surgical rhinoplasty, you first do the clinical assessment to see if they need it or not. Okay, and why? You would do Botox first, you bring them back after 2 weeks, and then if they wish to have their nose straightened with dermal filler, that will be a good time to do it. And as for where, as I've said, it will be in the nasal spine. So looking at this diagram here, so we're focusing at the green point, which, as you may know, is your orbicularis oris muscle. So this is the perioral region. So some of you will know what these muscles are, so feel free to shout them out or think out loud in your head. So this muscle in green here is your orbicularis oris muscle. As you can see, it's quite deep and it's a round muscle. This next muscle here in the next diagram is your depressor anguli oris muscle, which pulls the oral commissures or the mouth of the corner down. And here we have your mentalis muscle. And there's various other muscles mentioned here. As you look in the diagram, we've got your zygomaticus minor, major, risorius. So the focal point for this presentation is purely on the DAO muscle. Now, this is a very tricky muscle to inject, and quite admittedly, I have injected patients, and I would say on average, one patient every year will have some form of complication in the perioral region. It usually tends to be mild, and that's purely because everybody's anatomy is slightly different. Nobody looks like a textbook diagram. So, you know, I have changed my practice over time, and hopefully I will be able to share my tips for you in the next coming slides. So the focal point here is now the DAO. So this is quite a superficial muscle, and then deep to this you'll have, and medial to this is your depressor labii inferioris. Now this muscle will help pull the lip down. It lets you speak and drink out of a cup or a straw. So this is a muscle that you do not want to touch. And you can see it's deep to the DAO. And then even more medial to this is your frontalis muscle. So some of you that are doing frontalis muscle injections, you've got two options. That you could do an injection right down the middle like I do, 5 units, maybe 7.5 units, or you could split this into 2 injections just off the midline on either side. And again, the reason why I use one injection is just to stop the spread accidentally happening and going more lateral into the DLI. So this is a muscle you definitely do not want to hit. So how do we inject the DAO? So the best way, if you look at this muscle, it's like a triangle. So where are your chances of hitting this the most, regardless of anatomical variation? Is it going to be at the top where it joins the corner of the mouth, or is it going to be at the base? So it will be at the base. And we also know from anatomy that it's a superficial muscle. So where will we inject? I don't have that diagram here. I think there's a further few slides, but essentially we're going to be injecting at the base of this muscle. And the principle behind this is it's a triangular shaped muscle, and you're more likely to hit it at the bottom. And the best way to do this is get the patient to express themselves and get them to bring the corners of the mouth down, which I can't do very beautifully. And you're going to palpate and then inject 2.5 units of Botox, which is quite a small dose. It's not a place that you want to put too much in, because you will encourage a wider field of spread, which will then in turn cause a complication, which I'll show you later on. Sorry. So this is another muscle. So I did say to you the focal point is DAO, so your depressor angulae oris. And it's a muscle where I never really inject alone, and I always inject in conjunction with the platysma. And you think of trying to beautify the face. We want things to be lifted, we want things to be tighter, and the DAO is a very strong depressor of the corner of the mouth. And if your mouth corners are coming inferiorly, this is going to give you an impression, or give others impression, of sadness and sorrow and despair. So we want to make the face more youthful. Therefore, it makes sense to try and inject the depressors of the face. So the DAO in conjunction with the platysma. So this is your famous Nefertiti, and this is how it all originated, having a very nice, chiseled, sexy jawline. And this is an example over here of a nice chiseled jawline. There's 3 parts to the platysma: pars modularis, pars labialis, and pars mandibularis. And it essentially starts at the deltoid pectoral fascia, and then it runs up towards the lower border of the mandible. So this pretty much works in conjunction with the DAO, so it makes sense to do the platysma as well as the DAA muscle together. In terms of injection technique, if you look at this diagram, that's where you would inject. This is a picture I was looking for earlier on, sorry. So remember what I said, that the muscle is a triangular shape, so to speak, and you've got a higher chance of hitting it at the bottom. So that's your first point. And secondly, get them to express, make a feeling of sadness, showing you their lower teeth, and palpate the muscle before you inject. And this is your platysma. Now, if any of you have tried to do this and create this look, you can, I could do this for you just now. As you can see, to try and maintain that throughout your treatment process is quite uncomfortable. So a good way of injecting the platysma is get them to make this expression, and then very quickly with a sterile eyeliner, you could just draw down each of the bands and then just get them to relax. So that way you've identified where the bands are. I would identify the main deep bands, 3 or 4 per side, and then do multiple injections, as you can see in this diagram, multiple little injections along the band. And I do find it quite uncomfortable for patients when they are like this. So to get them to do this, mark the points and inject intradermally. So it's not an injection you want to be injecting deep. So why is that challenging? And if you take a look at this picture, that will tell you why. So again, this happens to me pretty much once a year on average, will I say. And again, it's purely down to anatomical variation. And over time, I have learned less is always more, always assess the face, and everybody's slightly different. So what has happened here? So if you look at the patient, she's trying to open her mouth, but on the patient's left-hand side, she's unable to open. So that's telling us that the depressor labii inferioris has been affected with botulinum toxin. Therefore, it has no strength in the muscle to pull the lip down. So she will be complaining of symptoms such as drooling and difficulty speaking, and quite an affected smile. So why would this happen? So too much toxin, or not knowing your underlying anatomy, so therefore the wrong injection. And how will we manage this? There's probably not much you can do at this stage. You could, if you're very daring enough, try and mimic the scenario on the other side, but then you run into the risk of enhancing her symptoms, such as drooling. So this is one of those where it is going to be a watch and wait scenario, reassure the patient, and it will subside. So coming on to something a little bit more interesting. So some of you can identify this muscle. This is your masseter. So this is one of 4 muscles of mastication, chewing. So you've got your temporalis, your masseter, and then you have your lateral and medial pterygoids. And here is a couple of diagrams just showing you the 4 muscles. And it's important to know where the masseter originates. And this originates at the zygomatic arch and the zygomatic bone, and it inserts at the mandible. And as I've said, it is one of 4 mastication muscles. The most important thing here to know is that there's 3 elements to this muscle. You have a deep compartment, or a deep muscle, if you like, intermediate muscle, and superficial. And in the lower third of the muscle, you have the deep inferior tendon. And I'll explain why that is important. So if we do Botox injections quite superficially into the masseter, then you're going to relax the superficial compartment. However, the deep compartment, where the bulk of the muscle is still going to contract, and this will herniate laterally. So therefore, you don't have an effective outcome. So the key point here is when you're doing injections into the masseter for teeth grinding, you want to be going in nice and deep. To be fair with you, even if you hit periosteum, as I said to you in one of the earlier slides, botulinum toxin will move up and down in the face. It's not a 2D effect, it's a 3D effect. So the key point here is inject very deep into the masseter, so you go beneath the DIT, and therefore you will be able to have an effective outcome. So if you have a look here, this is my markings. So on the left, you can see an example of a hypertrophic masseter, so bruxism, if you like, and you can see this is only 4 weeks later. Okay, and there's quite a gradual reduction in the masseter size. In terms of markings, so if you look here, this is your tragus. So from the lower tragus, I will draw a line to the oral commissure. So this line tells me you do not want to be going above this. And then you will draw a line along the jawline. And then you want to palpate the anterior border of the masseter whilst they're clenching, and you finish off drawing this line. So you've got this now quadrangular shape. Now, despite this being my safety margin, despite that, I still remain in the lower half of this shape. And I will do 5 injections of 5 units of Botox each, which is 25 units. Again, nice and deep, and that's, sorry, this thing is just frozen here. So yeah, four or five injections, nice and deep. So why is it challenging? So this diagram shows you why. So that can happen. Now that is a very exaggerated case, and you would want to make sure there's no other underlying issues, for example, Bell's palsy or a stroke. Now, the masseter is very challenging. And again, when I summarize complications, as I said to you earlier on, I always talk about injection related and Botox related. So when it comes to injection, you could cause bruising, a hematoma, headache, and localized pain as well. Now, there's going to be several toxin related complications. For example, reduced mastication force. Now that's understandable. So it is one of your main chewing muscles, and therefore they won't have as much power in that muscle. Temporalis hypertrophy. So if your masseter is not going to be working as hard, your temporalis is going to be going into overdrive. Asymmetry can occur, for example, this diagram, and paradoxical bulging, again, if not injected deep enough, with my rationing in that previous slide of why we need to inject deep. Loss of smile, so if you have no concept of where your superior border is, because the masseter actually runs quite high up into the face. But along that route, you have your risorius muscle, which pulls the corner of the mouth laterally. So we want to make sure we do stay quite low down when injecting the masseter. A sunken cheek in the anterior inferior region here, and that's if you're injecting, again, toxin way outside of the margin zone, and you're going to be targeting the buccinator, which is a chewing muscle. Difficulty opening the mouth. Again, if you don't know where the margins are and you hit the lateral pterygoid, they'll have difficulty opening the mouth. If you hit the parotid, they may have xerostomia, so difficulty producing saliva, or excess saliva, or not enough saliva, or thick saliva, and neuropraxia. So along the lower border of the mandible, we do have the marginal mandibular nerve, which is one of the 5 branches of the facial nerve. And neuropraxia can occur, and that will take around 6 to 8 weeks for that to normally heal. And your patient's main symptom then will be difficulty trying to smile and open their mouth. So in terms of just trying to summarize beautification, the first thing that you want to be doing is assess the face. Now remember, earlier on I showed you an oval shaped face and a heart shaped face, or if it's a male, it may want to be square-like. Then we're going to assess the upper third. Consider adjusting the brows, so making them high arched if it's a female face, or making them very horizontal if it's a male face. Middle third, assessing for nasal ptosis, and correct if that's the case. Lower third, as we spoke about, the masseter to try and slim the jawline for not medical reasons such as bruxism, but also for cosmetic reasons to enhance that heart-shaped face. And the oral commissures, which is your DAO. And again, you would always want to treat the DAO in conjunction with your platysma. So that does bring me to the end of the first webinar. I'm going to see if there's any questions that have been asked. So if you have any questions, please do type in the Q&A section and I will answer them one by one. My standard dose of Botox. So Kelly Pierce is asking me, what is your standard dose? So I typically use a 50-unit vial of Bocature or Botox, and I would dilute this into 1.25 mils of bacteriostatic saline, and each of my increments are 2.5 units. Rebecca is asking me, can you explain how you perform the chemical brow lift, but you stay out of the danger zone? The danger zone is lateral to the mid-pupillary line for 1 centimeter above. And when you're injecting the brow for a lift, you're actually injecting just underneath the tail of the brow, and again, injecting away from the orbit. So you're not going to be causing any unnecessary ptosis. Lots of questions being asked just now, so do bear with me. I am going to slowly get through them all. Maurice is asking, is that a good alternative to a tip lift using HA? To be fair with you, when you use hyaluronic acid, you always have that risk of having some form of vascular problems. Now, even the best injectors in the world will always carry that risk. Nothing is risk-free when it comes to injections, but we can reduce the risk. So if somebody has a very mild ptosis to the nasal tip, then it is a good idea just to use Botox because it's safer, quicker, and easier. From personal experience, I find you get a 2 to 3 millimeter lift 2 weeks following botulinum toxin in the nasal spine. Kathy is asking, is the DAO muscle injection superficial? Yes, it is superficial. So I tend to go in at 90 degrees. We have 5/8 of an inch length needle, and I go in about 1/3 of the needle. So I don't ever go in very deep. So it's quite a superficial injection because it is a superficial muscle, and some of the deeper fibers underneath will be fibers from the depressor labor inferioris. Okay, and Kelly is asking, what are you asking? What is the standard dose for the frontalis? So for the frontalis, I tend to do 5 base injections, as I showed you, 2.5 units each, and then the extra 2, again, that which I've shown, again, 2.5 units in each of those. Kathy is asking, what do you use in the Nefertiti injection sites? So for the Nefertiti, I use 2.5 units of Botox. So I will identify in total maybe 5 or 6 bands, and then in each band I will do 2.5 units and spread them 1 inch apart. And in total I like to use 50 units in the first session, review 2 weeks later, and then inject a further 50 units. What happens, so this is from somebody who's anonymous, what happens if you just do the DAO without doing the platysma bands? Well, nothing actually happens, but we're trying to think of the bigger picture here. It's, think of it as, for example, nasolabial fold. There's nothing wrong with just filling the nasolabial fold, but you'll have a nicer natural outcome by lifting from the cheeks. And the same principle, it makes sense doing the platysma with the DAO, and both of them are still essentially pulling the corners of the mouth and the lower lip down. So the platysma is still a very major depressor of the lower face. And for those of patients that have very fine lines and wrinkles in the neck, again, it's one thing making a beautiful face, but then if aging is very apparent in the neck, that's another reason to do them both together. Rachel is asking me, do you find that Botox works in the perioral region for smokers' lines? That's a very good question. And I used to use dermal filler for smokers' lines. I used to find each of the lines, identify a few over the top lip, and inject with a filler literally into the line, intradermally or subdermally, and just do linear threads with something very soft with a low G prime. However, what I found was when the patients were smiling, you could make out that they've got threads of product, which doesn't give that natural look. So my go-to choice now for smokers' lines is botulinum toxin. What do? I do 4 injections of 1 unit each, literally 2 millimeters above the vermilion border. So 1, 2, 3, 4. So 4 injections, 2 millimeters above the vermilion border, 1 unit of Botox each, and then review again in 2 weeks. Adrian, not a question, but thank you so much. Very informative, and will use this in my practice. You're very welcome, Adrian. Pauline is asking, would you treat the frontalis without putting units into the glabella? The answer to that is no. I do have some patients that have financial issues, so therefore they can't fund the extra treatment, for example. Then I would use ever so slightly lower dose and only treat the frontalis and only treat them quite high up. So stay very superiorly in the frontalis muscle. But it makes sense to do the frontalis as well as the glabella region. Why? Because think of it as a tug of war. Frontalis is pulling muscles up, glabellar complex is pulling the muscles down. Agnieszka is asking, how many units would you use in the jawline? So for the Masseter, I tend to use between 20 and 25 units, 4 or 5 injections, nice and deep at 90 degrees per side. Samantha is asking, when you inject the spine of the nose, how much of the needle do you insert? Again, for this, it's a very safe place to inject, and I would go in about half of the needle. If you hit the nasal spine, therefore you're very deep, nothing to worry about. Or if you're quite superficial, again, nothing overly to be concerned about. Remember, Botox will spread up and down amongst the layers. So to answer that question, I go in about half of the needle in. Daniel is asking, how do you feel about treating diabetics type 1 with Botox? There's absolutely no real, well, other than infection control, there's no real issue on my end to treat patients with type 1 diabetes. I do have a fair few that have autoimmune conditions or are diabetics, and I've never had a concern. Obviously, infection control and wound healing, etc. You just got to make sure that's all to the very highest standard. Dumilla is asking, what if we missed the middle injection point whilst treating the frontalis? Nothing happens. And again, there's no right or wrong answer when treating the frontalis muscle. You do your base injections based on clinical assessment, review them after 2 weeks. If they need more, you can always top more up. Lots of questions, guys, so do keep them coming. Sadia is asking, please advise regarding slimming the face. I understand I placed 25 units, each injection 5 units in the masseter, but what are the 5 points? So if you recall the quadrangular shape that I drew on the diagram, your 5 points are going to be in each one of those corners and then one right down the middle. And remember, the line is from the lower tragus to the risorius, that's your upper border, but even then I like to stay quite significantly lower than that. This webinar, sorry, will be getting uploaded onto YouTube, so you will be able to play things back in your own time and go through things. Dumila is asking, do I use the same dosage in the review if needed? Yes and no, actually. So if it's just a very subtle correction, then I may half the dose that's needed. Otherwise, if I feel there's still quite a bit of movement more than I like, or there's still quite a few significant lines, then I will use the exact same dosage. You're not going to be creating overdose by injecting your usual daily routine of Botox on day 1, and you do the same on day 14, you won't be causing any form of overdose. So you can inject the same dose. Gabriella is asking, what about migraine therapy with Botox injections? You mentioned in the beginning, do you have any guidelines, doses, and points of injections? It's a bit of a long question to answer here, but if you do find me on social media, as you can, I've left the details on the screen. I can engage in conversation with you. But in a nutshell, to answer that question, Gabriella, when injecting for chronic migraines, there's a few areas that you want to be injecting. So the frontalis is the first area. The second area, which tends to consist of 4 or 5 injections. The second area is 3 or 4 injections in the temporalis region. Then I go into the occipital region and I do 2 to 3 injections. And then I do 2 to 3 injections in the trapezius muscle as well. Each injection is 2.5 units into every single one. So you tend to need around 1 to 2 vials. So that's that in a nutshell. Menaz Khan is asking, would a 4mm needle be better for DAO? And what needle do you recommend for masters? So a 4mm needle doesn't make anything easier in facial aesthetics. I know some people are a fan of using a 4mm needle, especially when it comes to enhancing lips. Now, it makes sense why that would be the case, obviously, given the underlying anatomy and what we're trying to avoid. But what I have found from personal experience is the smaller the gauge of the needle, the more Botox you tend to lose from the tip. Okay, so I tend to stick to a 30 or a 32 gauge needle. So you don't necessarily need a 4mm needle. And in terms of the length, you're obviously here in the UK, so just use your bog standard 30 gauge needles, your yellow needles, which is 5/8 of an inch. But again, if you review your anatomy, then you'll automatically know as to what depths you're going to be going. But the good thing from a botulinum and toxin point of view is Botox will spread up and down between the layers, so you don't need to worry too much. Miriam is asking, what about the traps? I heard that there's an on-label use for the back headache pain in the trapezius. I do inject the trapezius muscle, which is essentially a back muscle, and I don't inject them in isolation. I do this in conjunction with occipital region, temporalis region, and frontalis when treating chronic migraines. Another anonymous person. For a man with strong corrugators and very deep depression in the procerus from weakening, would you still treat the procerus? Yes, so somebody coming in for the first time, regardless of how deep the lines are, it's nice to, one, educate them, manage the expectations, and always start off with a treatment that's less invasive is what I'm going to say. Whether you use fillers or whether you use Botox, they're both very invasive, but in terms of the risk they carry, Botox is going to be slightly less invasive. And fillers is not something I would routinely recommend in the glabella complex. I mean, the average distance from the skin to the periosteum is around 2.5 millimeters. So you don't have much leeway there, especially when your needle goes in. So if there's any of you out there that are injecting the frown lines with filler, as long as you are very, very superficial, and I will be coming onto this into my next webinar, which is fillers in the upper third. Sherelle is asking, when treating the masseter muscle, do you get them back at 2 weeks or leave it a little longer due to the density of the muscle? That's a very good question. Because the muscle is quite thick, I tend to bring them back after 4 weeks as opposed to 2 weeks. So I find that Botox injections in the masseter, it takes a little longer, as you said, because of the muscle density. So do bring them back after 4 weeks to assess. However, it is a good time to maybe just touch base with them at 2 weeks in case you have a mild complication. For example, the smile being affected. Maurice is asking, do you have any patients who have difficulty lifting their heads after Nefertiti neck lift? I've had one case in the past where they've had, I wouldn't say difficulty, the way they've described it was it just felt bizarre, is how they described it when it came to lifting the head up. And again, it's just one of those things, there's only so much of the spread of the toxin that you can control once you've injected it. So, it is a rare thing that I've experienced. However, it's a very safe and effective procedure to do. So I wouldn't worry too much about lifting your head. Again, stick with 1 vial of Botox first across the whole neck, and then review at 2 weeks and top up if necessary. I think if you go for 2 vials from the get-go, you may run into problems. And if you go back to the beginning of the webinar, I did talk about hyper-diluting the toxin, which therefore would minimize the risk that you're concerned of. Kathy McCullen is asking, are the Nefertiti injections quite deep? No, very, very, very superficial. So you're creating a bleb under the skin. So the injections are actually intradermal. Okay, so very superficial. So another anonymous attender is asking, how would you avoid eyebrow hooks or brows that are over elevated? So this is called Spock brow. Now that's out of your control. So if you're trying your hardest to inject the tail of the brow, or you're avoiding the lateral frontalis muscle, you're going to be creating a brow lift. And sometimes you'll find that you create too much of a lift, and that's very, very difficult to know there and then. And the only way you're going to know is probably around the 5 to 7 day mark as to how well they're responding to the Botox. So if they ever do become spocked, you bring them back for your review, and then 2.5 units at the top of the spock, and that will just lower the brow down ever so slightly. Again, my favorite way of lifting brows is filler, and this is something I will be covering in the next webinar. Natalia is asking, I have trouble getting my frontalis to hold. I use zoom in predominantly. Our rep has said there is a new paper out saying injecting deeper in the frontalis will help with this. Have you found this at all? I do read quite a lot of papers, so it'll be difficult for me to tell you off the top of my head. Now, I did cover this point about where you inject in the frontalis, whether it's intradermal or deeper, so you're intramuscular. Now, if you're having issues with the toxin lasting, so to speak, then I would suggest injecting deeper into the intramuscular layer. Now, I inject intradermally because I don't want too much spread. I rather have less spread and more injections. But if you find that it's not lasting as long or it's not as effective, definitely I would recommend injecting intramuscular. And again, there is no right or wrong answer when injecting Botox into various layers, because it will spread up and down. May also be worthwhile potentially trying a different product. Again, each of the products do have their own little characteristics, although they are they're very subtle. So hopefully that helps. So yeah, do inject a bit deeper. Dumila is asking, do I use the same dose in review if needed? If needed, yes. Otherwise, I try to inject slightly less. Miriam Samuel, can you teach us about how to do micro Botox? So this is basically what we call baby Botox. So you're hyper diluting the Botox. Now, what you can do is if you contact me either on Facebook or Instagram, and we can have a discussion about this. But essentially, we're just hyper diluting the Botox, and it's injected into a very superficial part of the skin. Therefore, you're not going to be affecting any deeper muscles. Classically, in the lower 2/3 of the face, when we smile, we have a lot of dynamic lines in this region, and you can't go deep with Botox, otherwise they won't be able to smile or speak. Therefore, you can hyper dilute and inject very superficially. Amy is asking, please can you explain hyperdiluted? Do you mix with more bacteriostatic? Yep, that's correct. So you just want to add more of your bacteriostatic saline than you normally would, but it doesn't mean you just pick a random number and you add more. You have to make sure the ratios are normal. For example, if I dilute Botox into 1.25 mil, just 50 units, I can potentially dilute that down into 2.5 mils. So I've diluted the Botox twice the amount. Dr. Mervat is asking, how can we use Botox for acne scar treatment? That's a very good question. There's a couple of very good papers on this actually, which I can send you the links. If you do, again, find me on social media, the information is on the slide, and I'll send those links to you. But essentially, we're using very, very micro amounts of Botox injected directly into acne or scars, and that will help soften the appearance. And obviously, keep in mind, if there's any active breakout of scars or, of acne, then you would want to avoid at all costs. Kathy is asking, please can you tell us the dose of the spine of the nose? 2.5 units into the spine of the nose. Maurice is asking, when injecting the DAO, does using medial to the base of the marionette lines a good landmark? Yes and no. Again, the best thing to do is get them to show you their lower teeth or gums, so get them to make that facial expression, palpate where the muscle is, and then you can decide if it's at the base of the marionettes alone. So, you know, you never want to be injecting Botox blindly to someone's face by literally putting marks on their face and thinking something's medial or lateral to it. Always get them to show expression and either see the muscle contracting or palpate the muscle contracting. That will always keep you out of trouble. Phoebe is asking, I was taught to use 30 to 50 units of Botox in the Masseter. Would 50 units per side cause too much facial slimming? Everybody teaches everything in a slightly different way. I am a huge fan of injecting slightly less, getting effective results. If they're happy, they're happy. If you need to inject more, you inject more. I think 50 units per side is quite an excessive amount of Botox, and the chances are you are likely to get some larger field of spread. Therefore, you may target the risorius muscle or the depressors of the mouth. Therefore, you'll affect their smile. So I would stay away from injecting 50 units in one go. So always start off with less. So yeah, 30 units sounds good. 20 to 30 units sounds good. Nadia is asking, are patients with a past medical history of stroke good candidates for neurotoxin injections? If in good hands. So once you're fairly experienced with the use of neurotoxin, then definitely. However, if they're having repeated attacks or TIAs, if you like, then you do want to stay away. But if somebody's had a history of a stroke several years ago, that's fine. That's not a problem. They are very tricky patients because sometimes it's about trying to create that symmetry, and en route in creating symmetry, we often then run into problems. So they're very satisfying to treat, and you can treat them, but just making sure that you've got the sound knowledge of the underlying anatomy. Heristina is asking, can you tell us about Botox in meso cocktail for skin treatment, and what is the doses of Botox in that case? This is going to vary quite significantly, because you could get 2 units of Botox and dilute it in a 10 ml solution cocktail of various other things, or you get 1 unit in 3 mils, which is obviously going to be slightly more concentrated. So message me privately and I will try and help you with that question. There's a lot of questions here that I'm trying to get through, you see. So send me a message and I will get back to you. Jas is asking how to treat the different types of gummy smile and if the technique for treatment is different. And Ranveer is watching with me, who I'm assuming is her son and wants a shout out. Hey, Ranveer. Okay, so gummy smile. So the reason why we have this is because of a very powerful levator of the top lip, which runs in this direction, and that's your levator laid by superioris aliquote nasi muscle, quite a mouthful to say. And essentially, lateral to the alar base, we want to be injecting 2.5 units perpendicularly, quite deep into each side. Now, that is only done if on assessment when they smile and you see a lot of gums. If when they smile, you don't see that much gum, but the lip rolls inwards, so the lip inverts, then that's treated slightly differently in that, and that's going to be treated like you do with smoker's lines. So small amounts of Botox just on the vermilion border, just to help either and roll out the lip. Lisa is asking, how long after the first appointment after having Botox can you top up safely? 2 weeks. Some anonymous person is asking, does injecting for migraine cause ptosis in some areas? Not to my experience, no. And you should be injecting quite high up in the frontalis, not in the lower half. Thank you, Hannah saying, thank you for giving up your time. Really enjoyed furthering my knowledge. You're welcome. Yvonne is asking, how many units do you use for the marionette lines? So 2.5 units into each DAO. Do you carry out any hyperhidrosis treatment from Arib? Yep, that's correct, I do. And it's a very similar treatment for hyperhidrosis as it is for the platysma or the Nefertiti neck lift. And this involves a full vial of Botox. So 50 units is what I use in each armpit. And I'm injecting very, very superficially. So I am intradermal. Jenna is asking, when you have a client with a heavy brow that leaves a crease across the bridge of the nose, would you suggest toxin or filler? So this is going to vary on an individual basis, obviously. So the filler will depend on their side profile. Now, if they are very straight on the nose, adding more filler, you're going to distort that profile, so may not be a good option. And it doesn't matter how soft the filler is or how you inject it into the area, you're going to cause distortion to the profile. So toxin will be a safer bet, and you're not going to be affecting their profile. If they don't have a straight nose, however, but they do have that classic horizontal crease, it may be worthwhile then putting filler in. But what you could do is put Botox in first, review in 2 weeks, and then decide if they need any filler. Sira's asking me something. I believe that may be in Spanish, so I'm sorry I can't answer that question. Lou is asking, do we need to sign up again for a new link for next week, or do we use the same link? A new link will be going out, so there will be a new flyer, there will be a new link, and that will be put everywhere on social media. So do follow the 2 accounts down below on Facebook and Instagram. Maurice is asking, how is injecting deeper into the frontalis lengthening the longevity of the toxin effect? It doesn't necessarily lengthen the longevity, but what we're talking about in theory is that if you're injecting deeper, you're going to be causing slightly more spread than injecting very superficial intradermally. Again, there's no right or wrong answer. It is a very gray area. So it doesn't necessarily affect the longevity. Lou's asking, if someone has had normal Botox in the forehead, can they have a brow lift with toxin? Yep, why not? They can both be done on the same session. Sadi is asking, is it superficial or deep in the spine of the nose? It's either or, really. Botox will be spreading to your depressor septi nasae muscle, and I like to go nice and deep. Helen is asking, for brow lift, do you inject on, above, or below the brow bone? I inject inferior to the lateral brow. Okay, so where the tail of the brow is, I inject underneath it, but in an outwards manner, away from the orbit. Lisa is asking, do you advise using Botox for a gummy smile? If so, what are the locations, points, and units in Azalo? So it's difficult for me to try and explain on myself, but essentially where the alar of the nose is, lateral to this, you're going to be going in 90 degrees, okay? And it's a nice and deep injection, and I use 2.5 units of Botox. And the conversion, they say, is on average, each unit of Botox equates to 2.5 units of Azalo. However, I tend to just double it, just to be on the safe side, especially in this region. So I would recommend 5 units of Azalo on both sides, nice and deep, and hopefully that will work. Also, with your index finger, press into that region and get them to smile, and you will feel the levator muscle pulling the lip up. If you do, fire away. Varon is asking, when do you evaluate the Masseter injection, like frontalis or later, because it is a skeletal muscle? I'm sorry, I don't really understand what you're trying to say, but when I evaluate the Masseter injection, I'm assuming you're asking, when do I look at doing the Masseter? So 1, if they're a grinder, if they have bruxism, or 2, when I'm assessing the outline of the face. And if I feel I could make it more feminine, then I would be injecting into the Masseter from a cosmetic point. Amy is asking, did you say you prefer Boccaccio? Please could you give a shout out to Kirsty, who is unwell but still watching. Hi Kirsty, get well soon. Yep, that's totally correct. I do prefer Boccaccio purely because it's cold chain, but you know, I get very good results with all 3 forms of toxin here in the UK. Victoria is asking, do you find Botox works well for sweaty palms of the hands? Yes, I do. I mean, off license, it can be used in the palms of the hands, in the soles of the feet, in the groin area. The only downside is it can hurt delivering these injections, but I find it very effective. And a bit like hyperhidrosis, they tend to last around the 8 to 12 month mark. Liz is asking, fab session, really informative. Can we watch it back? Yep, you can. So once this is done, maybe tomorrow, I will be uploading this onto YouTube. So do find the Academy of Aesthetic Med on YouTube, follow, and you'll always be updated. Maurice, this is one of the most informative webinars ever. Thanks so much. Thank you very much, Maurice. Brilliant. I think that's most of the questions. Right. So there's still 98, 99, 100, still 100 people in the webinar. Are there any more questions that you guys would like to ask? If there are, then please find me on Facebook and Instagram, Dr.G Aesthetics and Academy of Aesthetic Medicine. Please follow me on YouTube as well. I've only recently started the YouTube channel, which is where these webinars will be going, and I will be doing a lot more work on the YouTube side of things as well for you guys. So free content for you all. So do like, subscribe, and follow, and share the support. You're welcome, Emma. Thank you for the kind words. Right, everyone. So thank you very much, and stay tuned on social media, and we'll be in touch again with the next webinar next week, Thursday at 7 p.m. UK time, where we will be talking about dermal fillers in the upper third of the face. So I'll talk about the anatomy, injection techniques, and complication management. So thank you very much, everyone. Lots of love, stay safe, and see you all soon.